All right, so gait. We want to observe the gait from the front and back. So as the patient's walking away, we're getting a posterior view. As they turn around and walk towards us, that would be an anterior view. And we want an observation from the side as well. Now, we want to get down to the level of the patient's legs when we do this. So crouching down can be a good strategy for really being able to see abnormalities well. And from an anterior and posterior view, we might see certain abnormalities like differences in lumbar rotation. And we want to ask ourselves when we see abnormalities, could this be related to a lower extremity issue that's manifesting with changes in the back as well, or vice versa? So, for example, lumbar rotation can be affected by the amount of hip extension that we have. So, we might have a limitation in rotation towards one direction, which might cause compensation with excessive hip extension on that side. Or we might have limited hip extension on one side, which would cause an excessive rotation in the lumbar spine. Um, our lumbar lateral flexion, so we might see a corrective strategy for weight shifting as well. So this could be in relation to trying to recenter that center of mass with a weak glute med, for example. Hip adduction, excessive hip adduction we might see as well. So a lot of times with that hip abductor weakness, we might see that Trendelenburg type gait. Hip rotation, looking at the knee in respect to distance from midline can be helpful, especially the anterior view. And again, our inversion and eversion. And abnormalities related to lower extremities can make subtle changes in the back and vice versa as well. So from the lateral view, we might see more of a slouched gait. So kind of a crouched over position or a more flexed position in the trunk. With gait to try to diminish step length or stride length, that is, or potentially to try to limit the amount of rotation that's occurring. Same thing with hip extension. We might see excessive hip extension as a compensation that's derived over time, or we might see limited stride length, which might manifest with limited hip extension as the patient wants to avoid rotation in the lumbar spine. And again, knee flexion extension, which could be related to issues going on at the knee, like range of motion limitations that we might see with OA, or it could be related to a compensation from motion limitations in the back as well.